Thank you, Catherine. That was very an overview and actually very comprehensive overview of the CCSVI, and I found it very, very informative. So I'm going to move on to my part of the talk. Now we are into the new oral agents, and I'm going to talk in detail about a couple of these because they are, one of these has been actually approved just a month ago, and hopefully we'll have it on the Canadian market in the next 6 months or so. The other two probably in the next 18 to 24 months. I will talk briefly about what's under the Section 4, because these are agents that may take 3 to 5 years to come on the market, and those other points that I just previously discussed. So the first drug is fingolimod. I'm going to take this opportunity to also perhaps impress upon you as to what it takes for a therapy to get to the market. So this agent was called FTY720 10 years ago. At that time was used only in the laboratory animal world. And then over the next few years, as it showed benefit in that setting, and then phase 1 trials were done on human volunteers, then phase 2 trials on MS patients. So it took about 5 years to see that this drug does have some efficacy in multiple sclerosis and that it's probably safe to proceed with the phase 3 trial. And the phase 3 trial started enrolling about 4 or 5 years ago. The 2 phase 3 trials were completed earlier this year, already published, and based on those, FDA then gave approval to this drug. So I'm going to take this opportunity to show you the data on this drug. So now it has a market name, Gilenya. And this drug modulates a certain receptor on lymphocytes. And lymphocytes, or T cells, are supposed to be the troublemakers that cause most of the problems in multiple sclerosis. Not only that, this drug also works on the neural cells, i.e. it works in the cells within the brain, the neurons and the glia. So once again, the mechanism of action of this drug is that it works on lymphocytes and neural cells. What does it do to the lymphocytes? Normally, our lymphocytes, or T cells, are circulating, and they are getting in and out of the lymph nodes all the time. This drug prevents the T cells from leaving the lymph nodes. So it gets the bad guys in multiple sclerosis, puts them in, so to speak, jail, which is the lymph nodes, doesn't let them out. So they are not out there to cause more problems, and that's how this drug works. Its effect on the neural cells is kind of not really known in the human setting. It's only known at the animal level. So it's fair to say that there's some potential there, some promise there, but we don't know for sure whether it has an effect centrally within the nervous system. On the lymphocytes, though, we know exactly what it does. As you can see, the graph there shows that within 1 to 2 days, as soon as you start the drug, your lymphocyte count in the blood goes down quite dramatically, and it stays down. And the different levels of lymphocyte depletion are dependent on different doses of this drug taken. And the nice thing is that months later, when you stop the drug, the lymphocytes come back. Not within a day or two, it takes a few weeks, but the lymphocytes do come back, and therefore this effect is not permanent, it is transient. This is a bit of a complicated slide, but I will take you through this slide. There it is. And as you can see, the light blue bar to the left of the slide is the barrier between blood on the left side and the brain on the right side. On the left side in the blood are the T cells, or these aggressive lymphocytes, the troublemakers. And what do? They cross the blood-brain barrier, and inside release a whole host of harmful or pro-inflammatory chemicals that cause inflammation, which in turn acts on the myelin and disrupts the myelin and causes, therefore, demyelination. It also acts directly or indirectly on axons and neurons and causes damage there. So in effect, what you have is a lot of injury, which is this big red arrow. And when there's a lot of damage going on, in that setting, it's impossible for the brain to repair. So therefore, the repair arrow is very small. So this is in the untreated MS patient. So the next slide is now a treated MS patient, treated with fingolimod. So what happens is that, as I told you, the T cells on the left of the blue bar are now trapped in the lymph node, so they're not getting in, and therefore there is less inflammation, less demyelination, less axonal or neuronal breakdown, and so there were less injury. So you see now the injury arrow is smaller, and when there is not a whole lot of injury, the brain itself starts to repair. Not only that, if this drug indeed gets inside the nervous system, which we know it does, and it promotes repair, that would be a perfect combination, a drug that reduces injury and improves repair. So this is supposedly the mechanism of action of this drug. Let us see what it does in the real study that was done on patients with multiple sclerosis. So this is called the FREEDOM study. Started enrolling about 5 years ago and was finished about a year and a half ago. Data were analyzed, and then, like I told you, it was extremely positive, and therefore the drug is now in the market. I want you to look at this carefully. First of all, almost 1,300 patients were randomized to 3 arms. One arm was given higher dose of the drug, fingolimod, 1.25 milligram. One arm, patients got lower dose of the fingolimod, 0.5 milligram, and the third arm got the sugar pills or placebo. All patients got an MRI at the beginning, and they got MRI scans at 6 months, 12 months, and 2 years. And they got clinical assessments, those are the black arrows at the bottom, on a regular basis. And so at the end of 2 years, let's see what we saw. Before I tell you that, this is an extremely important slide to show you why do we need 1,300 patients. And this comes back to the SVI issue. 65 patients are not enough. Why not? Because to compare between one dose, the other dose, and the placebo, you need to make sure that you are getting, in the end, similar patients. And look at this. 1,300 patients randomized to 3 arms, so you get 430 odd patients in each arm. All of these patients are in the similar age group, 36, 37 years. 2/3 are female, as it ought to be, because 2/3 of patients are female. Duration of the disease, right from first symptom to the entrance into the trial, was about 8 years. Again, similar across the 3 arms. Number of relapses, in other words, how active were these MS patients in the preceding 2 years? It was 2 per 2 years, 2 per 2 years, 2 per 2 years, exactly the same. And their EDSS, which is the disability score, was about the same. And how many of patients had active MRI scans? Exactly the same. How many of patients were treatment naive, i.e. did not receive the first line, the interferons and Copaxone in the past? Exactly the same. So now we're talking about groups that have same baseline characteristics. And therefore, at the end of 2 years, we can say things with certainty. Yes, it is because of the treatment or placebo or not. So this is extremely important. This is called the power of randomization and the power of getting enough numbers into a study to achieve this. Now here's the effect. So at the end of 2 years, you can see this is the placebo arm. So the placebo patients during those 2 years had a relapse rate of 0.4, whereas in the fingolimod 2 arms, the relapse rate was lower down at 0.18 and 0.16. So that comes to about 54 to 60% reduction. And people look at this 54% and say that it's very important to know that it's 54% compared to placebo. And on purpose, I will show you the same graph, but with another bar here. Okay? So the blue bar represents the annualized relapse rate they had before entering the study. Remember, they all had 2 relapses in 2 years? 2 relapses in 2 years means 1 in a year, and that's what makes it 1.0. So the annualized relapse rate is 1. And look at how the placebo group did. 60% reduction with taking a sugar pill compared to baseline.